challenges we are facing, but also the opportunities we must seek to capture. This will be followed by an in-depth review of the impact of emerging and re-emerging veterinary and zoonotic diseases in Africa today. Tomorrow, we will deep dive into other key areas, including livestock biosecurity and climate change, social and behavioral interventions, vaccines and diagnostics, and of course, the need for technology innovation in a sustainable fashion. Please let me provide some administrative remarks to set the stage for this workshop. We really want to make sure that all of our global panelists have an opportunity to share their thoughts. Please stay within the times allotted for each panelist. As mentioned, the session will also be recorded. And if you would like to provide additional comments, please put them into the chat. So actually the panelists might be able to directly respond to either comments or questions you might have. Finally, please make sure that your microphone is muted when you're not presenting. So thank you for allowing me to co-open this workshop. And I look forward to the upcoming distinguished opening panel, which will be chaired by Dr. Dieter Schillinger, the Deputy Director General of the International Livestock Research Institute. Dr. Schillinger, please, over to you, and thank you for opening this workshop.
Yeah, thank you very much. And thank you both Dr. Rao and Professor Kai van der Horst for this nice introduction, which makes my job easier because I need to go into the details. The objectives are clear, and I just only want to make sure that from the experience we had at one meeting, it's very important to keep a little bit the time slots, and otherwise we run out of time, and that's not fair to the many speakers we have in the 2 days. So I am just only opening up the opening remarks session, and this is about getting the perspectives of the opening remarks speakers from their personal view and the view of the institution they are coming from. And it's a pleasure for me to start with Professor Agri Ambali, and he is the African Union from the African Union Development Agencies, and he's the head of the Science, Technology and Innovation Hub of the new partnership Africa's Development, the NEPAD in short. Over to you, Professor Agri Ambali.
So, Dr. Schillinger, unfortunately, we just heard about 2 minutes ago that Dr. Ambali will not be able to join, which is very unfortunate. But Professor Gassama will be opening instead for Professor Ambali. Dr. Gassama, are you available?
Yes.
She was just on.
Yes, I hope I can hand over.
Yes.
For the opening remarks. My name is Yaiken Gassama. I'm a plant biotechnologist. I was formerly in the government for many years, and right now I'm chairing the high-level panel on emerging technologies of African Union. So I'm very delighted to have this opportunity to share my voice and the voice of AUDA to speak about this important topic, which is safeguarding against emerging and re-emerging veterinary and zoonotic diseases in Africa. The latest pandemic has heightened the urgency to put in place mechanisms that lead to more preparedness, to be proactive and preventive rather than reactive in facing new risks that could arise from the interaction between human, animals, and the environment. Lack of biosecurity measures beyond health and environmental issues have a very negative impact on the economy. Loss of income and jobs, restriction imposed at the frontiers, loss of markets, disruption in the food chain, etc. And the World Health concept is particularly important and relevant in the context of emerging infectious diseases. such as those the world has experienced in recent decades. Biosecurity is fundamentally a One Health issue that aims to better address emerging diseases at pandemic risk through an integrated and multidisciplinary approach at local, national, and global scales. And according to the World Organization for Animal Health, about 6% of existing human infectious diseases are zoonotic, with about 75% of emerging infectious diseases globally having an animal origin. It has been further estimated that 5 new human diseases occur every year, 3 being of animal source. And we have here a gap and challenge, great challenge, because in Africa, millions of people are consuming, exchanging, and trading products from the slaughter of wild animals. And we know that these wild animals carry a large number of pathogens that cause emerging infectious diseases like Ebola we experienced recently. And here I would like to emphasize the importance and urgency of conducting training and research program in Africa on cross-species transmission to assess the mode of transmission of diseases between human and wildlife animals, to be better prepared, to provide advice and signals to prevent outbreaks in AID. More specifically, we need to establish a systematic surveillance system for zoonotic virus in a wide range of animal species, domestic and wildlife. And understanding wildlife pathogens, timely prediction, early detection, warning on potential emerging pathogens will help shift from a reactive response, EID, to a proactive one. Therefore, we need to harness existing and emerging technologies to address challenges posed by zoonotic diseases on our continent and largely the globe. So the African Union High-Level Panel on Emerging Technologies endorses a One Health approach to addressing shared health threats at the human-animal environment interface for a safer and healthier Africa. APET is encouraging African countries to increase efforts toward adopting innovations and emerging technologies so as to reduce infections at this interface, human, animal, and environment. And to effectively support this, APET recommends the establishment of a continental One Health platform, over which it shall play an oversight role. This platform would coordinate transdisciplinary representation of all relevant national and regional stakeholders. And the platform would also be designed to showcase continental One Health research, focusing on zoonotic diseases, surveillance, outbreak investigation, antimicrobial resistance, food safety, environmental health, and operational research. It would further highlight operational tools and guidance documents developed by African Union organs and our technical partners like WHO, OIE, and FAO. Finally, I'm hopeful that our discussions today and tomorrow will identify challenges and opportunities related to emerging and re-emerging zoonotic and veterinary diseases, and the preparedness and response capacity in Africa. It will further support discussions on the way forward, such as the proposed continental One Health platform. Thank you. I look forward to fruitful discussion.
Thank you very much, Professor Yoye. So it was great to give this overview from the perspective of the African Union Development Agency. And I think it's good to hand over to Dr. Jimmy Smith, the Director General of the International Livestock Research Institute, which, as you heard, is one of the co-organizers of this meeting. Over to you, Jimmy.
Thank you, Dieter. Colleagues, I hope you can hear me well. I'm very pleased to be joining this webinar, which is co-hosted by ILRI, the AU, NEPAD, and APARI. This webinar focuses on One Health issues, and particularly at the interface of responding and preparing for the control of veterinary and zoonotic diseases. I will appear on a panel to discuss the challenges and opportunities in a little while. But let me, at this stage, attempt to say why ILRI is so interested in this webinar today. Our colleagues who spoke before me have already emphasized the importance of this work. And ILRI's mandate, which is about using livestock to enhance livelihoods, is very much dependent on the success of One Health and biosafety, biosecurity measures. We have a very strong complement of staff working in this area. I'm told 47, perhaps the dominant profession in the whole institution. So we're well teed up to respond to the challenges and opportunities in this area. But given the broad scope of it, we also must work in close partnerships with many others. So partnership underlines our engagement in every aspect of this work, with veterinary departments, the private sector, other public institutions, and so on. And indeed, as we pursue this old approach, but one with which we're trying to reinvent to adapt to new circumstances, capacity development is a very integral part of this. And ILRI is also a strong player in this area. I'm often very pleased as I go around Africa and elsewhere in the world to meet so many colleagues who tell me that they have been here at ILRI in one capacity or another, but particularly to do graduate and postgraduate work. Much of what we do at ILRI is linked to these areas of veterinary biosafety and security, and adopting the One Health approach to these areas. So we work very much on zoonotic surveillance and detection. This, we believe, is the holy grail to early control or prevention. We work particularly with the governments here in Africa, but very closely with the government of Kenya in this particular circumstances of COVID testing and genomic surveillance. We work in the area of biosafety, biosecurity, and climate change. This relates to many areas. As climate changes, we expect that vector dynamics will change. And not only that of Rift Valley fever, the focus of our current engagement, but increasingly this link between biosecurity and climate needs to be pursued. We work too on improving the safety of informal markets. As we know, most of the food in Africa is procured in informal markets, without which food and nutritional security cannot be achieved. So making these markets more, improving the safety of these markets is a prime part of what we do and part of our focus. We know that vaccines are the cheapest means of controlling most diseases. And whilst large pharmaceutical companies are involved in this area, there are many diseases for which there are market failures. And these are the vaccines which we seek to develop here at ILRI. we also know that, as Dr. Rao said, we have lots of technologies, but they're not in the hands of those who can use it. So we aim with our partners at ILRI to not only develop, but get our technologies used at scale. So we see this webinar as a very important one, which we hope, as Dr. Rao said, will move from resolutions and action points to real actions in the field and delivering in this area that is so crucial to improving animal production and productivity, and indeed the livelihoods of those who use these animals. So thank you, Dieter.
Thank you, Jimmy. It was great to hear that, and clearly our ILRI's commitment to this area. And I hand over to Jean-Philippe Dopp. Dr. Dopp is the Deputy Director General from the World Animal Health Organization, or OIE in short, and in this function also member of the tripartite, the tripartite plus. So over to you, Jean-Philippe.
Thank you, dear Dieter. It's always a pleasure to work with you and with ILRI and other partners today. And I want to thank first all the organizers who invited OIE. OIE, as you said, is an intergovernmental organization responsible for improving animal health as World Organization for Animal Health. We have 182 members, including the 54 from Africa. And we are also recognized by the World Trade Organization as reference international sanitary rules. Africa is very important for us. We have 4 offices in Africa: Bamako, Nairobi, Tunis, and Gaborone. And we also established a One Health regional coordinator in Nairobi, Dr. Shadia Wanous, who supported me for this event, as she is now a One Health global coordinator at the OIE headquarters in Paris. So you see, Africa experience is well represented in our organization. OIE, as you said, promotes One Health for a long time as a fundamental competency of veterinary services, and position veterinary services as key actors in One Health. OIE also continue to integrate wildlife health, emergency management, and sustainability into the OIE's existing networks, mechanisms, and platform. You mentioned our membership of the tripartite. We're a member for more than 10 years. We cooperate with our FAO and WHO colleagues in this very important platform, who worked on rabies, avian influenza, zoonotic influenza, IMR. And today we expanded this cooperation to UNEP, which is very important to consider the environmental dimension of One Health. So One Health requires a strong partnership between the key actors in animal, human, and environmental sectors. For that, OIE works through a wide network of partners, including ILRI. We are pleased to participate in the One Health Research, Education, and Outreach Center in Africa, ORECA. We will be discussing how to strengthen our partnership with ILRI, which is very important. Jimmy Smith mentioned the multiple competencies of ILRI in the One Health domain, and it's very important to cooperate together. In particular, for some of the strategic thematic areas in the region, control of neglected tropical zoonotic diseases, emerging infectious diseases such as Rift Valley fever, hemorrhagic fevers, food safety and informal markets, which were mentioned just now, and prevention and control of antimicrobial resistance. Recent work of OIE on One Health includes advocating for the involvement of our organization and the veterinary services in the negotiation process of a new pandemic instrument or treaty. So this will be discussed within the WHO governing bodies starting from March 2022. It will be an important and strategic orientation. And we will promote veterinary services as key component of health workforces and as an essential element of One Health resilience. OIE also supported the establishment of OLEP. OLEP is a One Health high-level expert panel. I have the pleasure to remind that this panel is co-chaired by two eminent scientists, one of them being from Africa, Professor Vanda Marketer from the University of Pretoria, and the other being Thomas Mettenleiter from your home country, Dieter, as he is Director General of LFI in Germany. OLEP already released a new definition of One Health, which recognizes the health of humans, domestic and wild animals, plants, and the wider environment, including ecosystems. And so I take this opportunity to mention that One Health needs science. We need science systems for One Health. Many of you are scientists, and I strongly supported the establishment of this panel, and I strongly support the establishment and the strengthening of One Health science systems. The work on OLEP is supported by 4 working groups, including surveillance, which was just mentioned. And OLEP supports the 4 tripartite plus organizations to develop a One Health global plan of action based on 6 tracks. I will mention the different tracks: capacity building, emerging and re-emerging zoonotic, epidemic and pandemics, neglected zoonotic diseases, food safety hazards again, antimicrobial resistance, and environment and health. This work will trickle down to regional and country level through an implementation framework and resource mobilization. Biothreat reduction is also very important and is within our mandate. And OIE takes the threat posed by accidental and deliberate release of animal pathogens very seriously. OIE is implementing a number of activities that are aligned with the Global Partnership Signature Initiative to mitigate biological threats across the African continent. We support different projects. But as a conclusion, I will say that we must realize the critical contribution that veterinary services make to health and national security. To do so, we need to provide them with the tools, including scientific knowledge, political support, and the resources required to effective implementation of the One Health approach, particularly at country level. For this, we will continue to invest in international cooperation to better support our members all around the world, starting with our 54 African members. Thank you. Over to you.
Thank you very much, Jean-Philippe, and thank you also to refer to OLEP, because one of the confusions when we talk about One Health is that many different interpretation and definitions of One Health exist. And we were very happy as ILRI when OLEP came up with a clear definition of One Health, and I think it is really covering the most important areas, and it will help to focus all the institutions and scientists to work on One Health idea. So we have another tripartite member, WHO, and Dr. Suma Swaminathan, who is the WHO's first chief scientist, and she was coming in this position in March 2019. She can't attend, but she sent a video, and I think over to the...
Yes, studio.
Okay.
Yes. Start.
Greetings from the World Health Organization. I'm Dr. Soumya Swaminathan, the Chief Scientist, and thank you so much for inviting me to say a few words. The COVID-19 pandemic is a powerful demonstration that the health of humans, animals, and ecosystems is intimately linked. For many people, One Health may have once simply seemed a concept. It is no longer. We can only prevent future pandemics with an integrated One Health approach, which involves public health, animal health, as well as the environment that we share. One Health has to, of course, be more than a concept. It needs to be translated into systems at the local level that keep people safer. For example, we know that 70% of all emerging and re-emerging pathogens are zoonotic. And we also know that there is the possibility of the next pandemic, or disease X, as the WHO called it. We don't know when that pandemic will happen or where it will happen, but it is certain that it will happen again. But One Health needs to be more than just zoonosis. We cannot protect human health without considering the impact of human activities that disrupt ecosystems, encroach on habitats, and further drive climate change. And these activities include pollution. We have to think about both indoor and outdoor air pollution, large-scale deforestation and extraction, the intensification of agriculture and livestock production, the farming of both domestic and wild animals, the overuse and misuse of antibiotics, and the way that we produce and consume and trade food. The WHO definitely supports a One Health emphasis, which is also linked with the environment. And this has been actually outlined in the manifesto, the WHO manifesto for a healthy and green recovery from COVID-19. Indeed, it's quite ironical that it takes a pandemic and COVID-19 for us to drive change, to do things differently going forward. The whole world is interested in One Health now. It's going to be discussed at the forthcoming G7 and G20 meetings. Many national consultations are happening on this. There is a tripartite, which is the FAO, the Organization of Animal Health, and WHO, which along with the United Nations Environment Program, so it's a tripartite plus one, are really taking up very seriously the issue of tackling the whole area of One Health and formulating frameworks and policies to be able to also monitor it at the global level. We've seen a lot of collaborative activities, both at the global level, but also at the regional and the country levels. For example, there is a launch of the United Against Rabies Forum, which is an example of all the different agencies and stakeholders coming together to tackle the problem of rabies, which unfortunately still kills a lot of people in the world. We continue to make progress in establishing the governance structures that will curb the threat of antimicrobial resistance. For example, we have set up a global leaders group that held its first meeting this year. It's going to have regular meetings, and there will also be an establishment of an independent panel on evidence for action to tackle antimicrobial resistance. WHO is planning to scale up further investments in One Health and work along with the partner agencies to build consensus, to make sure that there's collaboration and have some action items which are priorities. And we need to ensure that all the partner organizations really come together and that governments also invest in this area of work. So we're at a very critical juncture now when we have recognized not only the importance of zoonotic diseases that can turn into pandemics, but also, of course, the present threat of climate change. And the one way to address all of these issues together is really to bring public health, disease prevention, and environmental protection and sustainable livelihoods, particularly in the agriculture and veterinary sector, all of these together. So if the pandemic has taught us anything, it's that we're all stronger together. We need the science. We need the science to drive and produce the solutions, but we also need the solidarity. And this is where another area which affects the world as a whole, and therefore we need global solidarity and collaboration to tackle this. Thank you very much.
Thank you very much. You can't hear my congratulations to a very good statement. And I think it was really important to hear that the WHO is now also part of this cooperation and working together. And because that was a principal issue with One Health at the beginning when it was started mainly as a veterinary initiative, and we always had a problem to include the human health people sufficiently. It's great to hear the WHO is joining this initiative, and I hope this will be also translate into cooperation with human health on regional and country levels as well. So, and I particularly like to hear the word of solidarity. You know, it's really a very important part, and we see the pandemic situation and the egoism coming up with vaccines and not sharing this. I think solidarity is another very important pillar to make One Health a successful story. So this session, we are really good at time, and I hand over to to you. Okay.
Thank you very much. Thank you, Dr. Dieter. I think you concluded very nicely, and I don't have to repeat it again. I just liked is solidarity, science, and technology. That was ringing all these lectures. Thanks to all of you for cooperating with us and giving fantastic opening remarks to start with. Now we have to move to the next panel discussion, moderated by a great friend of me and a professor of microbiology, infectious diseases, and distinguished chair of global health in Nock Institute, associate director. And he is one who has a lot of insight into African issues, particularly in zoonotic diseases. In fact, through him, I came to know lots of things that are happening in terms of projects and programs. And I now request Dr. Vivek Kapoor to conduct the rest of proceedings. I should also share a pleasure with him to all of you that we are the ones who successfully, after several discussions and negotiations, started a bovine tuberculosis network in India. I think still it's going on. There are hurdles, but I'm sure the goals will be definitely achieved. I am very proud of inviting Dr. Vivek Kapoor. I'm sure he will lead the panel smoothly. Thank you. Over to Vivek Kapoor.
Great. Thank you so very much, Professor Rao. Real pleasure to see you again, sir, and everyone here on this meeting. It's again a real pleasure to be part of this. As Professor Rao introduced me, I'm Vivek Kapoor. I'm a chair in global health and background in veterinary medicine. I'm also an adjunct professor at the Nelson Mandela African Institute of Science and Technology in Arusha, Tanzania, where it's been a real pleasure to have worked on with colleagues, very closely with colleagues, on projects founded by the Bill and Melinda Gates Foundation, the US Defense Threat Reduction Agency, amongst others. It's a real pleasure today to introduce to you our panel, who's going to discuss critical bottlenecks and opportunities for implementation of One Health programs of particular interest to low and middle income countries. That is where many of us work. That's where many of the issues that are of relevance to us are. And so I think this panel discussions going to be particularly illuminating in setting both the agenda and asking how it is that we might be able to overcome what these bottlenecks are. So we have an outstanding group of panelists. Let me introduce them one by one. First off, you've already heard from Dr. Jimmy Smith, who's the Director General of ILRI, the International Livestock Research Institute. Dr. Smith has served as Director General of ILRI since 2011, has extensive experience in livestock health and research related activities, including at CGIR, working with the World Bank, as well as with the Canadian International Development Agency. He's worked for quite a while at ILRI, and I think his experience in the field has been tremendous. So welcome, Dr. Smith. I'd also like to welcome Dr. Bhupendranath Tripathi, who's Deputy Director General of Animal Sciences at the Indian Council for Agricultural Research. Dr. Tripathi and I've known each other for a while, but he currently leads and helps establish the research agenda for what is about a quarter of the world's livestock population and about 1/8 of the human population in India. Professor Tripathi is trained in veterinary medicine, has extensive experience in the area of infectious diseases, including being widely published, and particularly in areas including Johne's disease, where he and I have worked on for a while. And prior to his role at the ICR, he served as Director General for the National Research Center on Equines and helped establish the Indian National Center for Veterinary Type Culture. Welcome, Dr. Tripathi.
Thank you.
Our third panelist is Dr. Jean-Philippe Dopp, who you also just heard from. He's Deputy Director General of the World Organization for Animal Health, the OIE, and where since 2016, he's led institutional affairs and regional activities, really overseeing a lot of the implementation of critical regional initiatives, including those that relate to One Health. Dr. Dopp has a background in veterinary public health, as well as in tropical veterinary medicine and animal production. Has served in many different roles across the world, including in Africa, where he started his career in Burkina Faso, and then moving on to France, Spain, and elsewhere. And now, of course, he's involved with international affairs. Welcome again, Dr. Dopp. We also have Dr. Silas Ubukosia, who's a Senior Program Officer at the African Union Development Agency, a co-sponsor of this program. Dr. Ubukosia has, it's a pleasure to introduce him, particularly because he and I are graduates of Penn State, so we're alumni of Penn State, so welcome. His background is in genetics and molecular genetics and in plant breeding, but has quite a bit of experience in areas that have incredible relevance to us, including biosafety, intellectual property rights, and has served in important roles in various places, countries in Africa, particularly in Kenya, where he's worked with the Bill and Melinda Gates Foundation, and as well as serving in roles in advising the US Agency for International Development in its biotechnology program. So welcome again, Dr. Ubukosia. And then finally, a co-founder and a critical member, one of the triumvirates of APAR, Dr. Sachin Chaturvedi, who's Director General of Research and Information System for Developing Countries, also known as RIS. This is an India, New Delhi-based think tank, and his experience and where his current work is focused is on issues related to development economics and development finance, particularly interested in South-South cooperation, which, as you heard early on, Dr. Rao suggested is really the reason for forming APAR to try and move the South-South agenda forward. Dr. Chaturvedi has a lot of experience in areas of trade, investment, innovation, and is also a member of the Board of Governors of the Reserve Bank of India. He's published over 20 books, including in policymaking, and is, I think, one of the foremost leaders in external sector economic engagements and partnerships. So welcome, Dr. Chaturvedi. Just a brief background here. Our session objectives, as I suggested, are to discuss critical bottlenecks. We have a limited amount of time, and so we're going to start with very brief introductory statements by the panelists, where they lay out in their views what the key challenges and opportunities are for implementing what we recognize to be as One Health related programs of relevance to low and middle income countries. And the request is for each of the panelists to stick with about 4 minutes or less so that we can lead on from that to our discussion, where we will spend about a half an hour, hopefully. So again, I'm going to start off. First off, perhaps Dr. Smith, I don't know if you have slides, or would you like to just simply discuss in the next 4 minutes? Welcome and thank you.
Thank you, Dr. Kapoor. No, I don't have slides. I just have a discussion. First, I must say, with the lineup of panelists that you've just outlined, I feel a sense of inferiority complex lining up against these luminaries. However, let me have a go. Some challenges. We hope that we can find ways to prevent zoonotic diseases with or without pandemic potential, but perhaps that's some distance away. If we were able to detect them earlier, we would still be able to save a lot of resources. As we know, the further away from detection, the higher the cost of control. So in the current set of circumstances, a key challenge is surveillance. How do we do surveillance that allows us to detect diseases of pandemic and non-pandemic potential much earlier than we do now? First challenge. Second challenge is, how do we get better institutional collaboration? The sum of the parts is much less than the whole at the present time. Institutions work vertically. What is my mission? What is my job description? What's my remit in this issue? We want a more, rather than a vertical, a more horizontal approach to dealing with the disease prevention and control. So rather than what is my mission, we need to ask what is the mission to be accomplished. So we must work more horizontally and less with these rigid institutional boundaries. And the third is, how do we create incentives so that we can get early detection and response much sooner than we do now, from farmers, from rural communities, from rural governments, national governments, and across governments. As you know, the story of South Africa recently announcing the Omicron and the whole set of issues which arose that were quite punitive of South Africa at that time. We will not be able to achieve early reporting and therefore early response if, when things are reported early by farmers or by governments, the actions are punitive. So how to incentivize actions that are not punitive that will also trigger early response? The benefits, therefore, are the converse of those things, I would say. If we were able to do early detection, we will derive a lot of benefits. In earlier work of mine and colleagues at the World Bank, we estimated in the days of high-path avian influenza that $25 billion over 10 years will bring us benefits of about $125 billion. Now, this was in high-path avian influenza, very mild pandemic. Put that in the context of the current pandemic, and one can see what might be the returns on investments in surveillance, particularly in low and middle income countries that are not able to afford it. We will derive so much more from this institutional collaboration about which I spoke in the area of animal-human health, and environmental health. These investments will present a lot of opportunity for us to do much more than we do right now. And we will foster a virtuous cycle by bringing about this institutional collaboration, such as been spoken about the tripartite +1. And then we must do the opportunities as much more in communication and education. At the present time, our approach, and until now, we learned from the pandemic that the approach that is largely about the economic returns is not all. We have learned about the real social and other costs of these pandemics. So education and communication are really big opportunities for us. Thank you, Dr. Kapoor. I rest there for the moment.
Great, many, many thanks, Dr. Smith. Dr. Tripathi?
Thank you, Dr. Kapoor. I am audible?
Yes.
Okay, thank you. Thank you very much for providing me this opportunity. And the agenda has already been set by the previous speakers and also by Dr. Kapoor. I would like to highlight that how India has been working in just a couple of minutes and how it's trying to tackle the One Health issues with many various programs which are run by Indian Council of Agricultural Research, One Health approach, then by Department of Biotechnology and Department of Health Research. And of course, and every program that Indian Council of Agricultural Research is collaborating with them. One of the most important programs that we have started in the country by Department of Health Research, where they have divided the entire country in 16 regional coordinators, where every regional coordinators have got 3 to 4 states, and where both veterinary and medical institutions are collaborating. They're developing laboratory infrastructure. And that's a very unique thing, where we are all tackling the local zoonotic problem there, trying to help our stakeholders also, and developing a type of a common laboratory there. So that is the one thing that has become very good. And at least we have been able to set up 12 regional laboratories like that. And a part of that, Government of India is also trying to strengthen the capacity building to the World Bank project. And also we have been trying to work with the ILRI, on some of the exotic diseases. And our international collaboration is already on with ILRI, and both Dr. Dieter and Dr. Smith is here. And now we are trying to develop them, working on the exotic diseases, including MERS coronavirus and Rift Valley fever. So that is the one thing that we have very, very soon we are going to start with the international collaboration. Now, some of the critical bottlenecks that I have been observing in our country and maybe in other countries also, that there should be enhanced collaboration between medical and veterinary institutions, because we have seen that how this COVID pandemic has really devastated the entire world economically in all fronts that have been affected. So let us have some of the common laboratories, a shared responsibility for handling these zoonotic diseases. Then strengthening infrastructure. We have got limited numbers of BSL-3 and BSL-4 laboratories. And in India itself, where we had only 1 or 2 laboratories when pandemic came, but now we have almost more than 3,000 laboratories. So this preparedness should always be there on war footing. As Dr. Soumya has very clearly said that when next pandemic comes, we will never know it. Then third thing is international collaboration. That is very, very important. And also the human resource development of diagnostics and vaccine, though we have been developing it, but now we need to change the vaccine development pattern also. We have to skip many things while developing the vaccine. Earlier vaccine development used to take maybe around 6 to 8 years. And also, I see a very commonality between veterinary vaccine and animal vaccine. Why can't we approach One Health vaccination for many diseases like tuberculosis, like Zoonosis, like Rift Valley fever? So that approach, we have to go for that. And then finally, the greater investment on animal health. That is lacking in all countries, including India. So that has to be taken care of. And then human resource development to deal with such like pandemics on a very short notice, and then effective communications. So these are some of the things that we have to really work on this, so that we can really we can tackle and handle with the this pandemic, and also in the future whenever it comes to. So this way, thank you very much, Dr. Kapoor, for this present.
Great, thanks for your introductory statements, and Dr. Tripathi, very good to see you again, sir. Dr. Jean-Philippe Daw.
Thank you. As you can imagine, I'm very happy to hear that we must invest in animal health. So I strongly support this. But as you ask me, what are the three most important challenges? I will mention first to make One Health not being a nice concept, theoretical concept, but really a reality implemented in the field. And this needs to relate to different themes, starting an initiative. Many One Health initiatives could be listed. OLEP started to list 160 around the world, and we will need a mapping to better understand which are the significant one, the most important one, and also to ensure a good coordination between all these initiatives. But for making One Health a reality in the ground, we need capacity building. We need to invest in capacity building, and this is, of course, a challenge. The second challenge I would like to mention is to ensure a good continuum, a good articulation between what I call the risk analysis step and the risk management and control step. So for risk analysis, we need science. We need anticipation. It was already mentioned. We need bodies like OLEP, but perhaps over connections. We need to rely our actions on a strong risk analysis system, and then to promote a strong risk management system. Again, by supporting our members and by investing in this support. And as a third challenge, I would like to mention the importance of data management. Data is also the key for anticipation and prevention, starting with the identification of emerging threats, the identification of emerging animal outbreaks. It is what we do through our World Animal Health Information System. But we need to break silos and to connect this information system for animals, for example, with the human animal health system, with the environmental health systems. We need to share data, and we need to do this with a good understanding of what are these data. WHO recently announced the creation of a new pandemic and epidemic global intelligence hub in Berlin. So that means that other organizations, starting with WHO, invest in data analysis, in data productions, in data sharing. So this is very important. But at the same time, the current pandemic offers new opportunities. So I mentioned data sharing, which is at the same time a challenge and an opportunity with the creation of the One Health Intelligence Hub. But as an opportunity and to remain at a global and multilateral level, I would like to say that the current context encourages us to better cooperate together. We mentioned already the tripartite. what we call today the Tripartite Plus, which includes UNEP, to better consider the environment health. We succeeded to set up OLEP in a very short time, only 3-4 months to set up such an important body. We generated numerous applications to join OLEP, more than 700. We work efficiently with them. There is a good articulation with the Tripartite Plus. We have a bureau each 15 days. We will finalize very soon the global plan of action for One Health. So you see, this generates a lot of energy, a lot of dynamics, and this is very positive. As a second opportunity, I want to mention the increase of the political interest, the political commitment for One Health. Yesterday, perhaps multiple politicians didn't know what was One Health, just a word. But today, they know what it is. We have more opportunities to promote One Health in G7, in G20. At this time, G20 is discussing together with the World Bank a new mechanism to establish a better funding for global health, including One Health, through a financial intermediary fund. So it is not only a political interest, but I hope it will be translated in financial support to global health and One Health. And as a third opportunity, I already mentioned that several times. I think that today we realize better that not only animal health and human health are connected, but both are connected with environmental health. This has also a positive consequence, starting from OIE. I could mention the wildlife framework that we developed, and we are currently implementing this framework. Better cooperation with UNEP, which is very important in this field. So I expect this cooperation to be more and more important, and I want to be optimistic on our capacity to address the different interfaces of One Health. Over to you.
Great, thank you very much, Dr. Dub. Dr. Silas Ubukosia.
Yeah, thank you very much. I want to thank Professor Gassam, who is our APETI chair. I want to thank also Barbara, my colleague, and Dr. Karim also. Yeah. I think we are focusing on the African perspective, regional approach. So there are three main opportunities. One is the policy and regulatory framework at the continental level. Yeah. Now, we have got various policies that could support veterinary, One Health, and human health, and many of them are already operational. One of them is Agenda 2063, the Science, Technology, Innovation Strategy for Africa, then also the Africa Continental Trade Agreement here. But one of the interesting things is that the program which I work with has been working on biotechnology policies for Africa, and we are in 23 African countries. The laws that have been established in these countries are both can be used for animals and also for plants. Yes. There are things that as we move into the new area of science like genome editing, we are also have a policy draft for Africa, which Professor Gassam and the group shall approve. And this forms a framework for impact in the whole of Africa. And one other interesting program that's interesting to health is that the integrated vector management program, yeah, where we are supporting the biosafety section of developing gene drives for control of malaria in Africa. And currently we are in 3 African countries here. So those are just an example of the policy framework on which One Health can build on here. The other one I think is the ongoing research. I think Dr. Jimmy may have mentioned, but his institution is doing a lot of research in some of these diseases, like contagious bovine caprine, like Rift Valley fever, East Coast fever, and there are about 11 applications that are being done at containment in these diseases, most of them carried up by ILRI, but approved by the Kenyan National Biosecurity Authority. So in short, there are platforms that can be used for that. The other aspect that is a strong opportunity is regional platforms. For example, there is a WAHU, West African Health Organization. There's a platform for a gene drive for elimination of malaria. There is CORAF, which is doing regional harmonizations on biosafety. There is COMESA and other bodies like PAMC. In other words, if you want a regional approach to have a bigger impact of more than one country, we have got those platforms here. Now, the challenges, one of the challenges that comes out strongly is the COVID year. And there's a paper written by our CEO, the COVID, the future of Africa development year. And he mentions there is decreased GDP because of COVID, there is decreased intertrade, there is increased poverty and food security. But one thing that comes out as a strength from that report is that he feels that health must be an integral part of socio-economic development of Africa, which means that One Health is just timely because we can't move from the experience of COVID unless health is part and integral here. One other challenge that is very, very important is that although we have got biosafety frameworks to handle gene drives, to have biotechnology in Africa, in 23 African countries we are on the ground, they have only been mostly used by plants, although they can be used for plants and animals here, except in a country like Kenya. So one challenge is that the animal science, the human science, the animal science need to come up with some research, with some products for this to be used and make sure that they're functioning here. So in short, there are great opportunities for Africa, which you can engage in a policy, research, and platforms, but the challenges come in that the health must be an integral part of it, yes, and that these policies need to be used by animals for them to be functional. And I will stop there and I say thank you very much.
Great, thank you much, Dr. Bukosia. Dr. Chaturvedi.
Thanks a lot, Dr. Vivek Kapoor. Let me at the outset congratulate Dr. S.R. Rao and Dr. Kai for excellent platform that they have created. I would very much like to congratulate the team and also the effort and the endeavor. I think the idea of One Health has come, and we would have to think of APAR as a possibility to connect. I have Dr. Kapoor put together a couple of slides that I would like to quickly share and would finish in the allotted time that you have given me. My idea is to address issues as they are in terms of what Dr. Rao said in terms of focus on One Health, and Dr. Soumya Swaminathan highlighted in terms of better effective coordination, consensus, and solidarity that she mentioned. And I think it's important for us to realize that the 5 T's which are important are technology, trade, transport, travel, and transmission. And these 5 T's are important in terms of how we attach economic importance, the trade importance, the idea of the non-tariff barriers which come up to allow trade and economy to expand without compromising the dimensions of engagement which are there. And from that point of view, I realize that the question of our engagement, the question of our partnership would be in terms of addressing these 5 T's, which I think are important. The
Dr.
idea.
Chaturvedi, your slides disappeared. Apologies. Could you share again, please?
Okay. Do you have it before you now?
Yes, thank you.
Thank you. So the idea is in terms of identifying the possibilities of One Health strategy, which is more a multi-sectoral, multidisciplinary, and multi-stakeholder. So it is not just an idea that only science agencies or health agencies can govern. As was very rightly mentioned, it is something which can bring in all different actors, including the actors which are part of the international relations, diplomacy, trade, and technology management. It is important for us to realize that LMICs require support. They need resources, they need technology, they need finance. And for that, the idea of partnership among the southern countries for South-South cooperation, SSC as it is called, and also partnership with the North, because northern governments were equally affected. So that is called as TRC, the triangular cooperation, and the South-South cooperation. So the whole approach would be to have the One Health concept for LMICs and bringing in the effective global guidelines that are needed, institutional mechanisms that are needed. And these dimensions can help us manage the big data, the digital traceability, and they can actually be playing an important role in the travel restrictions that have come up, or even the trade curbs that are there. We need to overcome that because economy has to expand, and without expansion of economy, it would be difficult for the southern economies and even for northern to assist the south. We need to see that we expand our economies, but we do not compromise on health. As was very rightly mentioned, human health is linked with animal health is linked with environment health, but health of economy is linked with all of them. And that requires us to see how several access, equity, and inclusion related issues are addressed. Now, friends, it's time for the South. This year, Indonesia is providing leadership at G20 in 2022. India would come in 2023, followed by South Africa and by Brazil. So next 4 presidencies of G20 are going to provide this. We need to see how resources can come in and can provide the necessary leadership which is needed. I would stop here and would be very much like to be linked further for any discussions. Thanks a lot, Dr. Kapoor.
Great, thank you so much, Dr. Chaturvedi, and thank you to all of the panelists for their opening statements, where I think common threads were pretty clearly made apparent, primarily around the challenges which are relating to not only the challenges for cooperation, integration, and the economic challenges, the challenges around prioritization, communication, and a fairly long list that we heard about. But then those challenges as opportunities as well, particularly around how we might be able to effectively implement One Health as a larger agenda, move it from what I think was called conceptual framing to reality, to practice, how we might be able to resource it, and then actually start to see what the progress on the ground might be through real-world examples of particular relevance to low and middle income countries. So thank you for that. I think the primary goal, as we know, is to focus on low and middle income countries. And I'm wondering, with the South-South cooperation or the triangular cooperation agenda that Dr. Chaturvedi mentioned, I'm wondering, how might we empirically establish what one would call the value proposition? Indeed, I think, as was already mentioned, governments now know what One Health is, but how might we empirically establish this value proposition? Because in the long term, in order to sustain this, Once COVID is done and over with, I think people will simply want to move on. I think the best opportunities, as Dr. Chaturvedi mentioned, and Dr. Smith mentioned, is to establish this as a value proposition right up front. So how might we do that? Dr. Smith, do you want to take a first crack at that?
Well, I think a good bit of that is being done already with the many, many studies that are coming out to show the impacts of a pandemic such as this that illustrates the value of One Health approach. We have seen studies not only about the impacts on economies, but also the impacts, social aspects of it, including health and education and so on. So the value proposition could partially be based on the returns on investments that we can make, given the assessment of what this has cost us. We certainly should come to the position that this should not happen to us again, at least in this scale. And we should not find ourselves as disarray as we are now. So I think that part of this value proposition is establishing the baseline that this pandemic has set for us as certainly a guide as to things that we do not want economically, socially, and otherwise.
Yeah, thank you for that, Dr. Smith. So you mentioned the World Bank had said that there was about a 5-fold return on investment for, on influenza, for example, on the avian influenza part. But yet it seems that the opportunity costs might have been greater, with potentially more returns of investment seen in other places. And so that investment was really never made at an adequate level, of course. And I'm wondering, are there lessons to be learned that we will forget that this pandemic will go, we will forget this, but yet that economic part really needs to be emphasized, and we need to show the value proposition as the trade-offs on opportunity costs. And it's not entirely clear to me where that might be coming from. Your thoughts on that, and then perhaps Dr. Chaturvedi, you could comment as well. You're mute, sorry. Yeah.
Sorry. Those who work in financing, whether it's development financing at the national level or global levels through the IFIs, find themselves in a situation where the demand for resources far outstrip the supply of these resources. And because of that, funding tend to be sort of lurching. We lurch from one problem to the next. And this has happened in the case of, we know many of the things we need to do to minimize the impacts of pandemics, but we don't do them because once it's over, we have moved on. Someone proposed in the comments foregoing in this session that maybe this has been a big enough jolt that politicians in particular would now know what One Health is about, will now understand the impacts of investments to prevent, because the cost of control are infinitely larger. So I'm hoping that that is the case, that this was sufficiently impactful, not only in economic, but social, psychological terms, that we will not walk away from this without maintaining a minimum level of investments that will guarantee us the returns, that not only the cost, but the opportunity costs are reduced.
Great, thank you. Dr. Chaturvedi?
Thanks, Dr. Kapoor. I think three issues to me, they are extremely clear, being very closely linked with development finance and its management, both at the global and at the regional level. I have been very closely watching the way IMF has responded to the crisis, and with the new proposed reforms of the spatial drawing rights, SDRs, now after G20 repeated requests IMF opened up a special window, and reforms of SDR led to providing something like $675 billion. And out of that, $375 billion have gone to OECD countries themselves, and only $21 billion has come to the low and middle income countries. So this lopsided approach that we have at the global financial architecture in terms of exclusion of the countries where huge masses are dependent. Africa has yet to have the quantum that is desirable for vaccines, and the amount of protection that is needed. The vulnerability has multiplied. The repeated exclusion of Africa and continent in terms of both development finance and also in terms of their ability to cope up with the health crisis, I think is an important dimension that is there. The second point is in terms of what goes beyond the public health impact of the regional and global emerging crisis, both in terms of endemic infectious diseases, but also in terms of the socioeconomic consequences that it brings in. And that, Dr. Kapoor, requires the amount of information that is needed for resources, for key partnerships, both public and private, but also in terms of the preparation for potential infectious diseases, as Dr. Soumya Swaminathan mentioned. So it requires a huge effort now to bring that in as part of our response architecture. And this is important in terms of the whole development finance architecture that is needed. The fact that the OECD has now talked about, as Dr. Kapoor, you referred to in terms of triangularity, more and more institutional architecture would have to be revisited. WHO is not part of the conversation in terms of how the finance is moving, but I'm really afraid it would require to be so. Japan, in its presidency, and Italy during its G20 presidency, has for the first time organized meetings of finance ministers and health ministers. This convergence has to come in, and this convergence not at the apex level of ministers, but also at the level of what Dr. Smith rightly said in terms of the regulatory architecture. The regulators would have to come together both for finance and those who are responsible for health, infectious protection mechanisms. And that would be the way forward for idea of One Health. Otherwise, it would just remain a slogan. It has to turn into practice. It has to turn into the reality that is needed. Thank you.
Great, many thanks for that. Dr. Dopp, your experience in this, I think you're the one who brought up the point that there is this awareness, and yet in your role from the OIE, with the work you've done with putting together OLEP and others, you're seeing this awareness and this interest come through. What mechanisms and what approaches are you seeing to build on this necessary, not only sustained interest, but ensuring that investments follow this interest, as Dr. Chaturvedi said, and that is sustained. Dr. Dopp, your thoughts?
Thank you, Professor Kapoor. Yes, and I would like to elaborate on what Professor Chaturvedi said. We gain more interest from politicians, from the highest level. He mentioned G7, G20, but we must now transform interest in money, in budget, in investments, in One Health. So we are part of these discussions as observer organizations. WHO is more in front of the scene together with the World Bank. We have proposals on the table through new mechanism involving the World Bank and the creation of a task force to discuss future investments, which secretariat could be operated by the World Bank and One Health. The next meeting of G20 on that will take place on 26th of January. Of course, we will participate. But when I see the documents that we received for this meeting, I see global health, but I don't see One Health. So that means that as the 4 members of the Tripartite Plus have to continuously remind that One Health is part of global health, that veterinary services, for example, are part of the health workforces. And when we invest in One Health, we prevent the future pandemic, we strengthen multilateral cooperation, and we are more efficient. And being more efficient, it's more value for money. With the same amount of money, you get more impact, more results. Because in fact, what is important is not to get money to develop activities, but to monitor if these activities have a true impact in terms of health and in terms of prevention of the next pandemic. And we should avoid what I call the one-shot investments. I will take the example of our World Animal Health Information System. We need to modernize the system. We are currently doing this, in particular to include the interoperability function, which will allow data sharing, which I mentioned previously. But this investment must be continuous, and we call it evolutive maintenance of our information systems. So yes, we must get more interest from the highest level, from the political level, but we need long-term commitment and investment to have a true impact on the prevention of pandemics and to better support our members. And one of the things I didn't already say is that when we invest in health systems, in veterinary systems, we are not only preventing the future pandemic, but we are also preventing what we call the transboundary animal diseases. That means also diseases which are not zoonotic. When we have strong laboratories, we have strong capacity of surveillance, and this surveillance is also useful for zoonotic and non-zoonotic diseases. Over to you.
Thank you very much, Dr. Dubb. Again, I think both the challenges and opportunities for trying to show this value proposition that might result in sustained investment is going to necessarily be a continued point of discussion. It seems, I think, Dr. Chaturvedi, as you mentioned, the health of animals, humans, the environment is inexorably linked with the health of economies. And I think it's that virtue cycle that will perhaps drive this sustained investments that we've all spoken about here. In terms of the other point that I think in both terms of challenges and opportunities that each of the panelists mentioned is quite striking about the need for cooperation, better communication, particularly between the various domains, the stakeholder domains, ranging from human, animal health, regulatory agencies, etc. These various stakeholder groups tend to be siloed, as has been mentioned by pretty much everyone. How might we get some progress on there, particularly given the awareness of this issue thanks to COVID? Dr. Tripathi, you mentioned the formation of these new laboratories, these 16 new laboratories that have been put together, and a newfound interest in cooperation in India. Can you briefly share your experience there and how you think this might be sustained for sharing accurate prevalence estimates, identifying new priorities for these emerging infectious threats, the next pandemic?
Oh, yeah, thank you. I think the Department of Health Services, Health Research, that comes under Ministry of Health and Family Welfare. They started a program about 3 years back. So they have a plan to nominate and develop 16 coordinators throughout the country, and each coordinators will look after, depending on the infrastructure they have, 3 to 4 states. And in these 3 to 4 states, whatever zoonotic diseases that occur in that area, whether it's a medical institute or it is a veterinary institute, they will be responsible for data generation, for surveillance, for providing diagnostic services, and so on and so forth. And that has really, I've seen that is progressing. They have already nominated 12 regional coordinators, and they are all working well. For example, I was at one of the institute where I was taking care of Haryana, Punjab, and Delhi. So similarly, all coordinators, they are doing very well. And then also they are developing human resources also. All medical and veterinary people, they are coming for the trainings. And I would like to share here with that many medical people that are not much aware of veterinary public health subject, you know. So they are also, sometimes they are astonished that in a veterinary diseases you have got so many of diagnostics, so many of vaccines, and perhaps they have been working in silos. So now that project, if we are able to develop a common laboratory for common laboratories throughout the country, in any country, maybe low or middle income country, that could be very useful. And that is also, that is also less expensive also, because if you are working on a brucellosis or tuberculosis, across laboratories, veterinary laboratory doing their own self, and medical laboratory, they are doing their for medical human purposes. So if you have got one laboratory, then perhaps the cost of testing will be reduced, highly reduced, and we'll have a very good surveillance data that is coming out of that. So that part I wanted to mention that.
Great, thank you very much, Dr. Tripathi. Dr. Obukosia, you'd mentioned in your experience on the biotechnology front that there's appears to be these silos, particularly between, even on the agriculture side, between the plant and the animal and the environmental side, and there's interventions that are moving ahead on the plant side that might need additional focus or perhaps investments on the animal and human side. Can you briefly explain how you see, what paths forward you see to get this better coordination?
Yes, one of the most important things we realize is that as much as we talk of regulatory frameworks, it's only when there is a product to drive that regulatory framework that different type of stakeholders get involved here. In other words, if we get a product or we get a research venture that combines human health, that combines animal health, that's the only way you can be able to put those different stakeholders together and they have collaboration. In other words, it's product or research driven and it's focusing on a particular problem for specific area. One of the most important things, for example, in the integrated vector management that is being employed in Africa, this is where, for example, the health workers, the environmentalists, the socioeconomists, and the entomologists have come together to solve Africans' problem of malaria. In other words, they are a research and product driven here. And that's what brings different people together. In other words, you must answer an economic problem, then that's the way to bring partners together. Thank you.
Great, thank you, Dr. Obukosia. I'm aware of the time, and I think in the last 5 minutes, if each of the panelists could comment on what they see as the one or perhaps two things that would help move the agenda forward. Primarily because given the context that nothing succeeds like success, we do need to ensure that best practices are being propagated. After all, that's what the cooperation is hopefully going to also enable. and that these tools are actually leveraged, which we heard many of the panelists speak about. So in your mind, which would be the one or perhaps two things topmost that would help drive the agenda forward? So if you had all of the special drawing rights from the IMF, $1 trillion, what would you invest in to move, in particular, the One Health agenda forward? Perhaps we can start with you, Dr. Obukosia. You're right up front here.
Yeah, it's just two things. One, if you look at the policies in Africa, they focus on agriculture, which covers health, which covers animal health, animal and crops. But in the recent realization, a paper published, it shows that socio-economic development cannot go on unless health is an integral part of that. So one, you have got the agriculture covering livestock and animals, then without health, we can move forward here. So that brings the three together and moves the agenda forward here. Thank you.
Right. Dr. Chaturvedi, if you had that $1 trillion, what would you do?
He's not there.
Ah, yeah.
He has to jump to some other.
Well, I hoping he's spending the $1 trillion wisely. Dr. Doc?
You said 3 million or 3 trillions?
1 trillion. Let's do it. 1 trillion.
1 trillion. 1 trillion, I imagine, should be for global health with a significant part in One Health. So I would promote to allocate a significant part of for One Health, which will be our challenge for the forthcoming G20 discussions within the joint health and finance group. So and for that we will need to coordinate together with the tripartite plus. And once I get a significant part of this trillion, I will fund our forthcoming global plan of action for One Health, which will include all the components that I previously mentioned through 6 tracks, with a significant part for prevention, for surveillance, for data sharing and analysis. I will respond to the question I had in the chat.
Yeah.
And a significant part, I insist, on capacity building to support our members. And capacity building will also allow to make the necessary connections between health, environmental health, and human health sectors to connect people not only during the training, but along their professional life. Over to you.
Great. Thank you very much. Dr. Smith, just the last 1 minute here.
Thank you. My feeling is that surveillance is the holy grail. The earlier we can detect things, the faster we can respond to them. Now, most high-income countries have the capacity to do this. The gap is in the developing countries. But there is enlightened self-interest for the developing countries to invest in surveillance in the developing countries, because what happens in developing countries can go other places very quickly. So surveillance, and I think we can build consensus around that quickly, because it is of mutual benefit to both developed and developing countries. The other place I would invest my money is that, given this rapid ability now to develop vaccines. Just imagine if we weren't able to develop vaccines, it took us the 8 or 10 years it used to take to develop a vaccine this time, how much more this would have cost us. So I think we should continue this work on keeping the scientific community in the area of vaccine development, but not on individual viruses, but on families of viruses, so that we can have vaccines that are more universal and be prepared for the next virus that could come along from whichever family they belong. Thank you.
Great, thank you very much. I see we're out of time. I take this opportunity to thank each of the panelists for their perspectives and contributing to this really informative discussion. I was particularly interested to hear their perspectives on how the value proposition might be demonstrated, leveraging, if you will, or building on the awareness that's been created by this pandemic and the opportunities that have arisen because of that, both in highlighting the gaps and highlighting the opportunities for us to work forward, work together going forward. The sustained interest and awareness, I think we heard a few solutions about, and I'm really glad this meeting is recorded, since we can go back in and try and hopefully summarize what the learnings are from each of the panelists in this session. So just a big cheer out, thanks to each of the panelists for your great comments and discussion. Over to you, Dr. Rao. Thank you very much.
Dr. Kai? Over to Dr. Kai.
Actually,
Are you on?
I'm sorry. So with that said, this was a fantastic panel, and I had the opportunity to take copious notes, which I will share at a later point. That said, I would like to now transition to introduce the Zoonosis Panel, Africa, Zoonosis Past, Present, and Future, hosted and moderated by Dr. Suresh Kuchipudi. Suresh, kindly take it away.
Yeah, thanks, Kai. Good evening to you all, and good morning to my colleagues from the US. Thanks, Professor Rao and Epar, for this excellent workshop. It's a great privilege and an excellent opportunity to participate and learn from all the views that were shared earlier. The focus of this session is to really look at the zoonosis. And I just wanted to remind all of us the reason we are talking about One Health is because more than 60% of emerging infectious diseases are zoonotic in nature. And the previous panel really laid out a very nice background in terms of challenges, opportunities in the context of low and middle income countries. So the goal of this panel is to zoom in a little bit, and we focus on the Africa context and talk about what are the challenges, opportunities. And the title is Zoonosis in Africa, Past, Present, and Future. And as you can imagine, this is such a broad topic and impossible to cover in 65 minutes. So what we try to do is to really highlight some of the key points that we want to discuss and address. We have 5 panelists, outstanding lineup of panelists for this panel. Dr. Kapoor, my colleague from Penn State University, distinguished chair in Huck Institute of Life Sciences. You just heard from his previous moderation of the panel. And Dr. Kapoor has kindly agreed to give the opening remarks so that we can lay the foundation of what are the key aspects of this panel and what are we trying to discuss. And we have 4 eminent speakers and panelists for this. Dr. Bernard Bett from OHRECA, Team Leader, International Livestock Research Institute. And Professor Zoram Bouza, who's a professor of immunology and also a Deputy Vice Chancellor of the Nelson Mandela African Institution of Science and Technology. And he has also been a great partner with Penn State and several programs with our university. And Dr. Adrian Muwan is a BBSRC Future Leader Fellow at the Royal School of Veterinary Studies, University of Edinburgh. And the last panelist is Dr. Matthew Maturi, who is a representative of Kenyan Zoonotic Disease Unit. So First, I would like to request Professor Kapoor to give the opening remarks. And I just wanted to remind the panelists that we have a limited amount of time. So we will stick with the key aspects of this panel. And some of the challenges Dr. Smith has raised earlier is surveillance and how we might detect the emerging pathogens early. And there are some critical gaps. And Dr. Swaminathan also highlighted very specifically that the coordination, consensus, and solidarity as the key aspects. So we will focus on those aspects so that we can address some of these challenges, but more importantly, what are the opportunities and how we can move forward. Over to you, Dr. Kapoor.
Great, thank you very much. Thanks very much, Suresh, for having me lead this off. Can everyone see my screen?
Yes.
Yes, excellent, great, thank you. Dr. Kuchipudi and I had a discussion with in what specifically we might wish to focus on out here. And I think he really nicely articulated several discussion items that we might benefit from, amongst others that I hope will come up in terms of our discussions during the panel as well. But I'm going to list the four areas where we might wish to focus and see how we might be able to move the agenda forward. So the first is around prioritization of what we might wish to work on. And this is a particular challenge for surveillance. Dr. Smith mentioned, Dr. Kuchipudi mentioned, Dr. Top mentioned, everyone mentioned surveillance as this key enabler where much of the funds and resources ought to go to. But what do we surveil? And how do we prioritize what we're surveilling for? And how do we then move that forward with sharing of that information? So what are the partnerships and collaborations that would be necessary for us to move forward with this? How might we then use that to improve the early detection at the animal-human interface? So we're all eagerly awaiting this new global pandemic preparedness agenda and roadmap. How might we actually move this forward to implement, particularly in areas where the existing surveillance capacities have really been compromised and has been shown to be very severely compromised, not only siloed, but inadequate to the task. And so in order to do that, what are those gaps we might be able to help fill? And I just want to sort of lay out the first question about prioritization and set the context here. Many of you have probably participated in some of the CDC One Health workshops. These are the One Health workshops, Zoonotic, basically the zoonotic disease prioritization workshops. 25 of them have been held thus far that I'm aware of since 2014 to 2019. 16 of these have been in Africa alone. And for those of you who have not seen this, the CDC has done a fantastic job of actually laying out exactly what the priorities were, the process. These are intense workshops. The process goes on for several weeks, months actually, in preparation. And then there's a well-designed methodology around which this prioritization occurs. And if you look across all of these 25 workshops over the 6-year period, what you really find is the diseases that are mentioned. I went back in and actually looked at each one of them, listed out how many times a particular condition made it to the top. Rabies was in each one of them as a top priority, and the numbers of priority diseases were from 1 to 10 across that list. So rabies clearly on top, influenza, brucellosis, anthrax, a variety of the viral hemorrhagic fevers. And I guess Rift would qualify in that one as well, TB, and then you sort of see a drop off for other ones that show up. And interestingly enough, if you go back in and perhaps run this workshop now, the emerging coronaviruses that were mentioned by two, one of which was the US, in fact, where this workshop was conducted, so not in Africa, was emerging coronaviruses. And that's really interesting because these priorities keep changing and they will keep changing based on available data. So how might one, in the absence of accurate prevalence data, begin to prioritize? And I'm hoping that this would be a major point of our panel discussion moving forward, because it seems to me that this is an iterative process, but yet we can't keep changing priorities and we can't keep building up so that we're surveilling for everything all of the time. So how might one establish this priority set that might be different between even, say, Kenya and Tanzania, or Kenya and Rwanda and Zambia? So how might one go ahead and do this? Again, these 16 workshops in Africa were pretty much all from Sub-Saharan Africa. So there's already a lot of information that's available and some shared learnings that we might be able to build from this moving forward. The other part that I'd like to sort of highlight is the partnerships and collaborations. We heard in the previous session about various stakeholder groups and how, in fact, without animal or human health or environmental health, there's no economic health, but yet you need economic health to drive this. So there's this wicked problem that we run into that actually, depending on which side of the perspective you're in, that's pretty much all we see. Yet these silos need to be broken down. How might we then establish those critical partnerships where self-interest is seen in moving this agenda forward in a virtuous cycle or circle? And how might we go about doing this with exemplar priority diseases that might help us move forward, both on the human, animal, environmental side of things? We heard as well about the improved detection. There's both technical, there's need for technical as well as social and regulatory improvements out here. So how might we actually move forward with that? I'm hoping that we can start to discuss in this next session as well. And then finally, we know that there are these critical gaps. We've discussed some of these, but which ones of these are those that we would want to go fill first? So how do we set about the priorities to do things first? How do we then build upon those, particularly of relevance to Africa? In the experience that we've had with many of our programs and projects that have either been ongoing or are ongoing, or have we've performed over the last many years, particularly in Sub-Saharan Africa, in India, in South America, and other areas of the world, where in fact this prioritization is important, is that the most important learnings were around communication and building that, building capacity at the human scale. So not capacity alone. A lot of people have built laboratories, but actually building capacity at the human resource standpoint, building individuals who are motivated and see self-interest to continue to work in this, and then making sure that those resources are available to continue down that. How do we actually build that capacity for surveillance and then the underlying technological, regulatory, and other improvements to move this agenda forward? sort of how I would see this. I want to just go back to this one word cloud that comes up, which is really prominent and predominant emphasis on a few diseases, right? These top ones. What I really worry about is that these are the top ones because they are the most charismatic, they are the most easily accessed or understood, but yet for many of these, we actually don't know what we would do after we surveil. So for example, for brucellosis or for anthrax or for tuberculosis, we might actually know what the answers are. We know what the vaccination strategies might be or approaches to test and remove to control these diseases, because indeed they have been controlled in many parts of the world, true for rabies as well. But yet the solutions that are relevant and implementable in some parts of the world are absolutely not implementable in Africa or in other parts of the world. So how might we actually have these very specific fit for purpose tools that enable moving this agenda forward? And I want to just hope that we can start to do this through this discussion, but continue this discussion through further very intense detailed workshop, and each one of these that are context specific. So I'll stop there.
Thank you, Dr. Kapoor. Yeah, thank you, Dr. Kapoor, for setting the stage and nicely laying out the discussion points for this session. We heard from previous speakers, and Dr. Smith also highlighted that the critical aspect of preparedness for future pandemics is early detection. And therefore, a couple of questions automatically come up is, as Dr. Kapoor raised, what are we surveilling for? Are we surveilling for the right things, or simply because these are the most popular diseases, therefore we are surveilling them for? And the second question is, what we do with the surveillance data. Is the surveillance generating data that is context specific and actionable? And therefore, these two important aspects will really help us to see if the data that is the surveillance is generating, is it actionable and context dependent? With that, I will request our first panelist, Dr. Bernard Bett from the International Livestock Research Institute, to share his views for the first 5 minutes. Thank you.
Yeah, thanks a lot. Bernard Bett, as you said, I'm the team leader for the One Health Center in Africa. I had a few slides, maybe I can just show them, but I really don't have to follow them because I think the discussion will change a bit based on what you are now projecting. I had prepared to focus on 3 main questions. One is the challenges we see in terms of measuring zoonosis burden, and that really affects investments in many countries, because if you don't have data, as we have said before, then you really don't know what to do. The next point which I wanted to highlight was looking at the past historical studies which have been done. What are the gaps and what kinds of partnerships that we have had in those studies? And I wanted to end with just a word on the future and increasing risk of emerging infectious diseases. So let me quickly go through them and then I'll address your questions. So the first one on burden, we look for these estimates everywhere. We really don't usually find them. You search for literature, you search for studies, and in many cases, they are either focusing on one disease or they are not really well presented in a way that you can use to address the question that you want to do. So of course, we know for COVID, it's good because, things are being monitored and we have estimates of deaths in the WHO websites. But if you look at other zoonotic diseases, which we have in the WHO website, the estimates on burden on zoonosis is very scanty because they are focusing on only very few indicators of zoonosis, mainly leishmaniasis, cysticercosis, echinococcosis, yellow fever, and rabies. And if you look at the percentage contribution of those diseases to the overall DALI estimate, it's quite small. But I think this is a major underestimate, and really this dampen or really limits investments in countries in which those diseases are occurring. It's unlike, if you look at infectious diseases like, malaria, TB and other diseases, those ones are well captured and they represent around 20% of the overall DALYs. So we have a challenge in zoonosis, which we really need to find ways of filling it. Other estimates from World Bank are already published, but for also specific diseases. The second gap which I wanted to address is past studies. And there's a very good publication done by one of our colleagues in ILRI called Elisa. She did the past 100 years of zoonosis research, stretching all the way to, I think, I think it's 100 years from 2021. And this is focusing on the Horn of Africa. And as you said earlier on, I think you are very right in terms of looking at which diseases are people working on, mainly stretching from brucellosis, echinococcosis, and then there's rabies somewhere. And very few of these other diseases are studied in the region. So the same work, if I minimize this, the same paper highlights gaps which are there in those studies, and mainly it includes the list of study diseases are not necessarily aligned with country priorities, and that's a major gap. I think you mentioned one of the gaps you were saying is we may be knowing already the control options which we should use, but I think the other one is, even if we have these studies which have been done, those studies may not, the diseases selected for studies may not be aligned with what the countries need to work on. This duplication of work, and many of these studies are descriptive. They really don't give you analytical evidence on what to do. And most of them are focused on animals. This is where the limitation of One Health, but maybe because One Health has really come into force in the recent years, that is understandable. And I think going forward, One Health will be more prominent in what we do. And the last comment which I wanted to give is on going forward, looking into the future. We know the human population is really rising, the climate change and urbanization. And when that happens is, we break our environments. That interface between humans, animals, wildlife is really enhanced. And so there's a huge opportunities for spillover events to occur. And mainly we look at key viral families, which are usually responsible for the many pandemics like odomyxoviridae, filoviridae, paramyxoviridae, and coronaviridae, which are responsible for many of the diseases we see currently. And that could be the main challenge. And one of the studies we are doing in Uganda under one of the BMZ funded project is Rift Valley fever, and it's mentioned by many people already here. And in our mapping, we want to overlay the epidemics and endemics. And what we realize is there's a huge gap in terms of if we continue only looking at areas where epidemics are occurring, then we are missing the point, because there are many other areas in the country where the endemic transmission is happening, but nobody knows about it. So what I'm proposing here is, I think we need to do much more analytical studies and more predictions so that we can be able to know, to get the full picture of where the risk is, and that can really help our surveillance and risk assessments going forward. And I think the other two comments I already mentioned in the slides, which I mentioned earlier on about reliable estimates for burden, as well as building capacity, which of course our colleague from OIE also mentioned that we need capacity in terms of analysis of data and using information that we generate from surveillance. So let me stop there. I think I could then address, if you want, I could address then the question you raised about, or we wait for the other panelists to do first and then we come back to the questions.
Yeah, thank you, Dr. Bett, for this nice overview. So we'll be discussing those questions in the panel discussion later on. I think you quite rightly pointed out a couple of important challenges is that the information we are generating through surveillance is not really based on the priority for the country in many instances. So we are not looking for a disease because it is of relevance to the country. And the other key aspect that you highlighted, which is, I think, very, very important, is that if you look at certain places where there are outbreaks, and we are not looking at other locations, and the disease prevalence estimate is very skewed simply because we are not looking in those places. So it's not that there is problems do not exist, but we are not looking at them. So the question is then, how do we change the way we surveil so that the surveillance data is more relevant and context dependent? So we'll get back to that thoughts in the discussion. So now we'll move on to the next panelist, Dr. Jerome Buza, Professor of Immunology from the Nelson Mandela African Institution of Science and Technology. Over to you, Professor Buza.
Thank you very much. I'm very happy to get this opportunity to give my contributions. I'm coming from Tanzania, and maybe I will start with the issues around Tanzania, and maybe I can go to the global level. And as far as zoonotic disease in Tanzania, the way Vivek has put it, we did a zoonotic disease prioritization exercise, and the diseases that came on top were rabies, Rift Valley fever, and other hemorrhagic fevers, zoonotic influenza, anthrax, human trypanosomiasis, and brucellosis. And this prioritization was based. It was a panel of experts from Tanzania and some abroad, and they set together, and it was mainly by voting. And voting means you vote based on what you think is a priority or important. But the major criteria were the presence of the disease in the country, the socioeconomic impact of the disease, availability of intervention, and potential to cause epidemic or pandemic, and the severity of the disease in Tanzania. So those were the main criteria for selecting these diseases. Of course, unfortunately, this was not based on surveillance data, which should have been actually maybe the driving force. And this is because we don't have a surveillance system nationwide. You can see for humans, the human demographic disease surveillance is not national. It is in specific areas, and it is targeting some specific diseases. And it is also project-led. These are funded by projects, and once the project ends, the surveillance system also disappears. On the veterinary side, the veterinary surveillance is rarely backed by laboratory confirmation. So the information we get from the surveillance system that is ongoing on veterinary side, it is just a diagnosis which is based on the judgment of the field's assistant. And not all the time they are very correct. So you can see there is a very, very big problem. And therefore, I can say the system in Tanzania is not really set for a very good surveillance. And I talked about the deficiency in of course, the surveillance system as a whole, but in fact, the lack of laboratory. We don't have laboratories to be able to confirm diseases on time. And this, the way Jim Smith, the Director General of IRRI, put it, if we cannot have early detection of diseases, then I think that that's where the problem starts, because by the time we came to realize the problem, it is already a countrywide and also international. And so this is a big challenge. And therefore, one of the things that I was suggesting is really to build laboratory capacity. Laboratory capacity. Like for Tanzania, I don't know which, maybe there are some one or two laboratories that are supposed to be I cannot say state of the art, but they are really better. Maybe they can do some molecular diagnosis, but they are not part and parcel of the surveillance system. So you find that they are rarely involved in the surveillance. So, and also there's another thing. The other problem is that at the national level, there is the One Health organization is still fragmented. We have the Ministry of Health, Ministry of Livestock, and the Ministry of Environment, and so on. And then we have a national One Health desk, which is under the Prime Minister's office. This desk is maybe with only 6 staff, and they are poorly funded. Actually, they don't have a budget for themselves. So every time there is like an outbreak of a zoonotic disease, you will find that actually the Ministry of Health, because it is relatively well funded, they are the ones that send a big team. And then maybe the Ministry of Livestock is relatively poorly funded, so they will send a team that is not really enough to be able to collect enough data. The wildlife sector is a little bit well funded, so maybe they will send a better team. But you find that each team is working on its own. Although they are calling an umbrella on One Health approach, but almost every team is working on its own, and they are receiving instructions from their bosses. So we are still working in silos. Therefore, I think one of the things that needs to be done is the structural transformation, to have a One Health, not desk, but a One Health like a directorate, which is well funded and is the one that is charged with dealing with zoonotic diseases. So maybe this one will change the situation. And of course, I think another thing we need is investment. I think the surveillance is very, very poor funded. Therefore, I don't know what we can do to make the country change the attitudes towards the disease surveillance. It is very difficult for people, maybe like in Tanzania or like Buza, to stand up and say, surveillance is underfunded, so please, we need to increase the funding. It will take maybe an international effort. Vivek talked about the value, to show the value for surveillance. Locally, it might be a bit difficult. I think we need an international agreement which will force the national establishment to change the attitude. And of course, the other thing is international collaboration, because when we work together, like what we did for the COVID-19, then the deficiencies in one country are kind of neutralized by the efficiency in other countries. And I think those are the aspects that I felt were important as far as Tanzania. And I'm sure the approach that I'm thinking about is that if we correct the situation on individual country, then we are going to have corrected the situation at the international or continental or international level. Thank you very much.
Thank you very much, Professor Buza, for that overview and insights from Tanzania. I think, as you rightly pointed out, laboratory infrastructure and the limitations of lab diagnostics has also been raised earlier from the context of low and middle income countries. So I think you rightly pointed out the need for accurate laboratory diagnosis rather than what the field staff thought the disease might be, which is critical for getting accurate measurements of prevalence of a disease. And it's also good to know about the prioritization process that was done for Tanzania. We certainly look forward to learning from the experience in Tanzania, how that might inform disease prioritization for Africa, as we discuss in the panel next session. So now we'll move on to hearing views from Dr. Adrian Mavon from the Royal Dick Vet School in Edinburgh in the UK. Dr. Mavon.
I do have some slides to share, so I hope I can be allowed to share those.
Yeah, please do.
So I actually wanted to talk about my experience. Well, my name is Adrian Mwonge. I'm a Chancellor's Fellow now, and my specific area of work is Digital One Health. That really involves a deliberate effort to build technology that allows for collective data generation between the human and animal health, and sharing that data to support zoonotic diseases and all One Health aspects, taking into account the limitations of ethical aspects that data inherently has. And really, this is sort of the area that would allow for these two disciplines to work together on issues, for example, zoonotic diseases. I'm also involved in capacity building through the Fleming Fund, and this really also works on leveraging the One Health platform in implementing the national action plans for controlling antimicrobial resistance in Uganda, Kenya, and Malawi. And this also really ensures that the stakeholders in those institutions are trained together. This allows them to understand the limitations of the other sector and therefore work together with an understanding of the limitations of the sectors that they come. But as part of my talk, I really wanted to give an example of how a process that I've been involved in, taking research from from the field at regional level, and how that research then is taken into global policy with regards to a zoonotic disease. And the zoonotic disease I'm going to talk about here is tuberculosis. Formed a very big component of my graduate work, and so obviously zoonotic disease is caused by Mycobacterium by M. bovis, which causes bovine tuberculosis in cattle, but it is transmissible to humans through milk and meat and or contact where that is possible. This affects about 140,000 people every year, and unfortunately about 120,000 of those succumb to the disease. It's regarded as a disease for poor countries, and the reasons I will explain a little later on. But it's one of those diseases that cumulatively really affects the productivity of the herds in an area, but also as and when the human populations in those places get this disease, because it's a chronic disease, it really does severely affect the population economically. The challenges around this disease is diagnostics, and this is one of those diseases where the diagnostics actually for M. bovis exist, but the problem is the motivation for actually doing the test. In the human sector, when somebody gets tuberculosis, the most important thing is to establish whether they actually have the bacilli. They don't care whether it is MTB or M. bovis, because the treatment has to start as soon as possible. So there's no motivation for anybody to determine whether it is M. bovis or MTB. As long as it is the bacilli, then the clinician will start with the treatment. In the animal sector, because the disease is endemic, the cheap diagnostics that could have been used, the skin test, really will turn positive almost on any animal, either because of environmental mycobacteria and or because of real exposure. So there's no motivation for anybody to surveil this disease in an endemic setting other than in the abattoir when the animal is slaughtered. And when the animal is slaughtered, then the populations have to come against food security. The question whether the meat is safe to eat or not. And that question whether a person should eat the meat or not is really dependent on the economic status of the individual. So the diagnostics then take on a really different terrain. And yet they are really the foundation that feeds into surveillance, because if you can't detect the disease, you can't surveil it. It's one of those challenging disease that you have the diagnostics, but the motivation to take the diagnosis is really skewed because of other parameters. And obviously, surveillance is difficult for this disease because it's endemic, and most of the evidence we have currently on the continent is from funded research, which comes with specific and narrow objectives. There is a general lack of awareness of the risk of the disease, especially because it is transmissible through food. There are cultural aspects that are embedded within food in certain parts of Africa, and that detaching the consumption of food in a specific format really means that you have to do a bit more awareness and you have to have evidence to demonstrate that the risk exists. And because the evidence is not there, so it's really this difficult situation that you find yourself in. And of course, the socio-economic aspects really do affect both the awareness, but also the diagnostics, as I have described. So, as part of my graduate studies, I was also the secretary, but also the chair of the Zoonotic TB subsection at the Union, which works in collaboration with the WHO. And when I was the chair, we were mandated with creating global awareness about this disease, but also to bring the stakeholders together at that level. And we did we also had to couple that with research, and we had ongoing research in Cameroon, Zambia, Uganda, and Ethiopia, which allowed us to generate critical information that informed the bringing together of these stakeholders. Now, the image you see there is a lymph node from cattle, and this is part of work that we did in Cameroon. And for every 100 animals that cattle you saw in the abattoir.
Dr. Mwange, sorry for the interruption. I think we'll move on to the details. We'll come back to this during the panel discussion. But thank you very much for laying out the important aspect of risk awareness, because to mitigate the risk of zoonotic disease transmission, risk awareness is really critical. And thank you also for highlighting the social economic impact. In the interest of time, we will now request our next and the last panelist on this panel, Dr. Maturi from the Kenyan Zoonotic Disease Unit, to share his views. Thank you.
So thank you very much for the opportunity. So I'll very quickly, in 5 minutes or less, take you through some of what I consider as critical discussion points when we have to think about the past, the present, and the future of zoonotic diseases in Africa. So I think the first question for me, because I saw one of the questions was around prioritization, was the big question about endemic versus pandemic, what we call the high burden, low impact diseases versus the low burden, high impact diseases. And the question we ask ourselves are, what are our real priorities? And if you look at my third point, again, there's sort of a bit of a conflict of interest or thought when it comes to what us as policymakers at times consider our priorities versus what the communities we serve and work for consider as their most important priorities. And so the main question I have, and it's a thought process we have in Kenya, is do these standardized tools, for example, the CDC tool that were presented, really reflect our reality, or does it reflect our reality as technical people and policymakers, or does it really reflect the realities of the communities around us? And I think these are some of the things I would want to discuss in the panel discussion. The other question or discussion point that came to mind when it comes to thinking about the present and future of zoonotic diseases in Africa is the uniqueness of our systems in Sub-Saharan Africa. You know, we always talk about surveillance, but the truth is the realities of surveillance in a lot our cultural setups has significant challenges and is unique in its own ways. And some of the tools that we have developed for surveillance, question is, do they really conform, or do they really answer our surveillance needs? And I'll give the example of Kenya, where we have a significant of the population that is pastoral because they live in arid populations. We estimate around 10% of our population should be pastoralists. And you know, we have the same surveillance system that serves the entire country. In high potential zones, the same system serves the pastoral zones, yet there are extreme differences in production systems, people's, how people live and such. And so there are realities around how viable these national surveillance systems are, and because of the uniqueness and diversity of some of the communities that we serve. So a big question around surveillance, of course, is the diversity question and how it affects the validity of the data we collect. Again, porous borders is a big issue in Sub-Saharan Africa and the Greater Horn of Africa. We get a lot of livestock from Tanzania, Uganda, Somalia. So how does this impact the burden of zoonotic diseases? How does it impact our surveillance system? How does it impact the animal health surveillance system, our animal health system as a whole? The other point that came to mind is the utility of surveillance data. We are doing some work trying to compare or trying to see how we can sort of share zoonotic surveillance data on zoonotic diseases across different sectors. And there are significant challenges in the data points that are collected. And also there are quite significant challenges in regards to some of the numbers we are seeing across sectors. So for diseases, for example, like anthrax, for example, where we see a lot of human cases reported, but in very few livestock cases reported. And we know the reality is it's impossible to get for humans to get anthrax if they do not get it from animals, because we do not have cases of intentional release in this country as of yet. So there are big questions around sharing of data, how data can be utilized across board. And again, this brings me to the second point of where we've seen a lot of the times humans serve as sentinels for livestock outbreaks. So where, for example, in diseases RVF, ideally we should start detecting this in livestock before crossover to humans. But a lot of the times these spillover events are missed. So yet some of these things were known before. So there are, of course, there are questions around how we can improve the utility of the data we collect as bad as it could be. And the last discussion point, the thing that came to mind was the reality of public health funding. Preventive versus promotive care in government is a big issue. A lot of the times policy makers will want to fund what is seen. That's a lot of the times preventive care. In human health, a lot of the times these are people build hospitals. In livestock health. A lot of the times people will want to build animal clinic setups, but funding for preventive health, surveillance, things that cannot be seen is a big problem, and this is the reality of the setup that we live in. So what can we do to improve this situation? And actually, I'm sorry, it should not be preventive as a provocative, but preventive as a curative care. And because like in Kenya, for example, there's a significant difference in funding for what we get in preventive versus curative care. And yet we know preventive care issues like surveillance are critical in detection and reducing the burden before people start getting sick in the first place. Again, the other issue that has always come up is the issue of human versus animal health funding, and yet we are supposed to control the zoonosis and maintain the same level of professionalism, same level of technical capacity. Yes, there's a big discrepancy in the funding. So how are we supposed to pull up the animal health sector to get to the same level of funding, yet we have human health dealing with issues like HIV, TB, a lot of the top 5 mortality. If you look at the mortality indices, the top 5 will be issues.
Dr. Maturi, thank you very much. Sorry for the interruption. Thank you very much for those excellent points. I think you clearly laid out some of the challenges. So I think this is very clear from all the panelists that clearly highlighted some of the major challenges is gaps in our infrastructure, lack of laboratory infrastructure for diagnosis. And in order to respond to the diseases or early detection, a critical aspect is that do we have reliable prevalence estimates? And it is clear from all the comments made by our panelists that there are very limited resources in many of the African countries where a laboratory diagnosis can be done and a national level surveillance programs. So in the absence of such critical infrastructure, it is perhaps clear that the prevalence of disease estimates or what we know about which are the top diseases in those countries is probably not very reliable. So therefore, an obvious question is then in the absence of such prevalence estimates, so what do we surveil for? So I wanted to go back to the comments made by Dr. Kapoor at the start of the session, which are, I think, the most important in this context is what are we surveilling for, and how do we prioritize in a specific context? So I just wanted to request Dr. Kapoor to comment on what are some of the aspects or framework that these countries could use in order to start the prioritization process when we do not really know what are the most prevalent diseases in the country.
Great, thank you. Thanks, Suresh. It's a real tough question. So the CDC uses, as I think Dr. Buza mentioned, these 4 or 5 criteria by which they go about making these priority lists. To me, it seems that the priority list, as I think several have mentioned, are sort of these beauty contests, right? So which one comes on top? There's a voting system, typically that's involved with multiple stakeholders, and that generally involves political posturing and self-interest, which one stakeholder feels is important versus another, who's represented and how well they are positioned to articulate their case. And that, I think, resulted in this massive variance across developing these priority lists that could change very dramatically should there be just a different set of stakeholders. And so I think, as we've all said, it's the underlying data that's not available. So how does one move forward from this? There's an optimization problem, there's a data deficiency problem. You can't parameterize your models so well in order to understand what your output functions you're optimizing for even. Is it economic gain? Is it political gain? Is it animal health? Human health? What is it that we're trying to optimize for? So I think perhaps the framing might be different if we think of this as an iterative process that has to be local and context dependent. So if you start from knowing what actions we might be able to take in order to prevent something or treat something or get some benefit to a particular stakeholder group, those are the ones that we might wish to optimize for first. It's very difficult to see interventions for influenza as a preventative being the top for everything when the underlying diseases at the farmer level might be something else. So it's very much context dependent. So what's good for the country, what's good for the world might not be good for a farmer or a region. So trying to make sure that we are aligning the incentive structure as well is critical. I think also being very open to the fact that we know that this is an iterative process. So we have to get more reliable data. But the only way to get that data is people are interested in getting that data. And it seems to me that from the experience we have is that the most reliable data sets are driven by individuals who are passionate about actually moving a particular agenda forward. It's people like Adrian, who's passionate about tuberculosis, or Buza, who thinks nothing but anthrax or PPR. These are the issues that I think once you have those individuals identified and those champions identified, we automatically get many, many years and decades worth of good data on which we can build. So focusing on identifying those champions and moving forward becomes a really critical point. And then finally, I think it's the economics at the end of the day. If you don't have an intervention or you don't have an option to do at the end of surveillance, it's no good just simply collecting the data. And then showing the economic benefits of that becomes critical.
Thank you, Vivek. I think that is really a wonderful point, that it is an iterative process, but more importantly, we have to be able to clearly articulate what are the societal impacts of that data, so that surveillance has an economic impact and a meaning to the society. And I also wanted to go back to points made by our panelists about the need for investments in laboratory infrastructure and the lack of lab diagnostic facilities in Africa currently. But I also wanted to remind us that the comment made by Dr. Dopp about we have to be careful about the one-shot investments and need to really think about sustainability. It is not simply enough to establish modern laboratories, but then a plan for sustainability of how do we might sustain them for a long term. So maybe Dr. Buza and Dr. Bett, you want to comment on what are the critical gaps, or how do we approach the investments, because there are so many things we could do. And as Vivek was mentioning earlier, if we have the $1 trillion, what do we do? But when the funding is limited, what are some of key aspects of investments in animal health infrastructure? Is it laboratory or people, or how do we approach this? Dr. Buza first.
Yeah, of course, you have to look at the current status, whether the gap is on the people, or the gap is on the infrastructure, and see which area you need to improve. But in general, like in Tanzania and most places in Africa, both the infrastructure and the personnel, they're all poorly prepared, to deal with the task at hand. But you put, I think, a correct question. You build a big laboratory, very sophisticated, and this is actually a situation in most African countries, including Tanzania. You get a project, you buy good equipment, you train people, and then after the end of the project, there is no sustainability, everything dies down. And at the end, you find equipment sitting there. They've not been used for the past 5 years since the project ended, and so on. So the sustainability issue is a big problem. And for something to be sustained, my feelings are that, it has to move from project-oriented things to something that has to be mainstreamed within the government system, which means it is also budgeted for every year. And that is how it can be sustained, because other than that, you know, it will just be projects coming and going away and no more activities. But now, how to make something look so valuable to the government to the point that now they will commit funds. That is where the trick is. That's where the difficulty is.
Yeah, completely concur, Dr. Buza. I think the sustainability part and the investments into programs rather than projects is very critical. So thank you so very much for that thought. So finally, I know we're running out of time. I just wanted to ask one last question about data sharing. So we heard multiple times about the silos, and the animal health system and the public health system often do not talk to each other, and the data sharing do not happen. And Dr. Mwangi mentioned about the investments in digital technologies that might allow such data sharing. I just wanted to have a quick response from Dr. Bett and Dr. Mwangi about what do you think if the data investments in digital technologies is the only solution for data sharing, or do we have to make a structural change in the way these entities collaborate currently? Dr. Bett?
Yeah, thanks for that question. I think systems per se alone may not change much. Okay, it will help it facilitates the interaction, but I think we should aim much more at building trust and collaboration amongst the entities or the sectors which are working together. Because already, maybe if you look at what we have currently in Africa, we have ARIS, which is being run by AU-IBA, we have mobile phone systems, we have electronic systems in many countries, and even at subnational levels, we also have online databases. So if you look at the additional investments that's required, may not be that much, yet we haven't really moved that much in terms of data sharing. We have the facilities. So I think the main focus should be building trust, building collaboration, and really coming back to the first question we are asking ourselves is the value proposition, so that if people understand that we gain much more by working together. I think that will be the main driver.
Yeah, excellent point, Dr. Bett. I think that really reflected in the comments made by Dr. Swaminathan about the importance of coordination and consensus building. Final thoughts from you, Dr. Mwangi?
If you allow me 30 seconds to respond to the previous question about the laboratories, I actually think there are any number of labs in Africa that have equipment, but they do not have reagents. And the cost of bringing reagents to these labs is prohibitive. Even if these laboratories wanted to create an economic model in order to provide a service, the cost of reagents makes it really impossible. So if you can find a logistical solution to bring these reagents to these labs at a cheaper cost, I suspect we'll have more labs working. Now, back to the question about the digital work. I think bringing in the private sector and combining this with the digital tools is actually a useful way of expanding surveillance, because the motivation for the private sector to use the tools is there because it is how they bring their service to the people. The farmers have an incentive to use the tools because that's how they get that service. And if you harness that combination, it means that the farmers can provide extra information that allows you to do surveillance on the farm whilst they engage in the service provision. So that is how we are trying to actually harness technology to improve how we can surveil some diseases, but also how antibiotics are used to as low a unit as an animal.
Great. Thank you so very much. Unfortunately, we ran out of time and we actually ran over time. But I really want to thank all our outstanding panelists for these excellent topics. I wish we had more time. These are major questions and major challenges. So clearly, we can't solve in 60 minutes, but I think the panel certainly highlighted some of the critical gaps and potentially opportunities going forward. So thank you all panelists, and give them a big round of applause. And over to you, Kai. Thank you.
Truly a big round of applause to everybody. It falls on me to provide some closing remarks. My goodness, what an incredibly rich dialogue that we had today. It provided truly deep insights into the challenges for advancing prevention preparedness for emerging and re-emerging veterinary and zoonotic diseases. Allow me to take 5 minutes to kind of summarize some of the points that were made today, as it also set the stage for tomorrow. I want to lead with a chat comment by Jean-Philippe Doc. I think that really hit it on the nail. No strong economy without strong health, no strong health without strong One Health, and no strong One Health without long-term commitment and investment. Truly remarkable on the point from my perspective. We heard about the increase of the tripartite on One Health and the importance of strengthening veterinary institutions as a means to strengthen overarching health security by establishing coordinated policies, be supportive of these policies, and build integrated capacity. The G20 summit objective, which was mentioned on the side, to recover together and recover stronger, is a critical step towards that goal and will advance the need for comprehensive strategies that inform comprehensive multidisciplinary preparedness and response policies and capacities to prevent future pandemics. So what I've heard a lot is this cross-cutting horizontal collaboration, communication at the state and local and supranational level that needs to be accelerated and facilitated. Regulators must come together to ensure changes that are implemented sustainably. We've heard that there are multiple platforms in Africa, including the Agenda 23, and also platforms around WAHO and COMESA, that provide the policy and regulatory frameworks at the continental level that a One Health program can be built on. In summary, though, on this, coordination, consensus, and solidarity are key to accomplish this. There's a universal consensus around this group that science needs to drive the solutions, but we also need global solidarity. It is essential to implement One Health solutions in a cross-cutting manner, leveraging multi-sectoral, interdisciplinary, multi-stakeholder approaches. We must assure that those solutions are relevant at the local, regional, and supranational level, and it needs to happen through South-South and North-South collaboration. What's really key is that accurate risk assessments informs accurate risk communication and response. That in turn must inform integrated capacity building, pointed capacity building, and technology innovation strategies. Ultimately, it is essential that innovations and technologies get to the people who can use them, where they are relevant, fit for purpose, and sustainable. We need to assure that technology innovations and access to those are equitable, especially when it comes to vaccines, therapeutics, and diagnostics. We have heard about the need to establish systematic integrated surveillance systems in Africa that cover the spectrum of human, veterinary, and wildlife health surveillance. There's a call for a continental Africa-wide One Health surveillance platform, and that is what is needed. But as we all said and stated and heard, is how do we get closer to the point of disease emergence? How do we detect outbreaks earlier? And what are the enabling technologies and solutions around this? We need to strengthen low-income countries' surveillance systems and capacities. So sustainable laboratory systems and networks are critical, and they need to be maintained in the interests of local, regional, and global health. Here we're coming to a point that is very near and dear to my heart as a managing director for the Pandemic Prevention Institute of the Rockefeller Foundation, which focuses on data sharing and data discovery and building systems around this. And we were very much at the middle of what happened in South Africa as our partner SERI discovered the Omicron variant. And then we saw in real time how the global North shut down flights, ruining industries, and it became a punitive action. So how can we create environments where data can be shared without resulting in punitive actions? We need to have incentives for data sharing, but what might they look like at different levels? I think Dr. Kapoor made that very clear and was very eloquent about it. So what are the economic benefits of sharing data? Without that, we will not achieve early discovery. We need to consider data as a global public good, and that came up in the chat messages on many levels, to be shared and organized data sharing through multilateral cooperation mechanisms of guidance. Financing mechanisms are critical. Developmental finance is critical. Investment must be continuous. A long-term commitment to support and protect our global members is essential. And again, this comes back to the G20 talks that are coming up. We also need to improve, and this was raised by Professor Gassama, we need to inform, we need to train, we need to educate, also at the community level, on the associated risks of disease transmission. As it comes to bushmeat consumption as a major food source, there's a major concern of the role of informal markets and the spread of disease. These are big opportunities we cannot miss, and there's also the element of social and behavioral intervention, which we will be covering tomorrow. A comment from my perspective, really on a positive side, one consequence of COVID-19 is that at long last, there is global attention to and recognition of the importance of building on health security capacities, sharing of data, knowledge transfer, and coordinated equitable preparedness and response mechanism. I believe that there has been enormous progress, but there's also much more that needs to be done. We cannot afford that as soon as this pandemic fades from memory, complacency takes over in what has been dubbed a cycle of panic and neglect. I want to echo the independent panel for pandemic preparedness and response, stating this cycle must end. And I think a workshop like what we have today contributes to the thinking of how we might do this. This has been a great day. Once again, on behalf of the organizing committee, I want to extend a really big thank you to the panelists and their truly exceptional contributions. I'm very much looking forward to seeing this excellent dialogue being continued tomorrow. And with that said, I wish everyone, depending on where you are, either a good morning, a good afternoon, and a good evening. And thank you for attending today. Dr. Schillinger, Dr. Rao, any last words?
No, you summarized it so nicely. There's no need to add something. But just only a great day. I enjoyed it very much, and I think it was fantastic to hear from the speakers. It was really good. Thank you very much to all of you.
My side, I reiterate the words of Dieter. He really summarized very well. In fact, I'll put your summary in the chat box tomorrow for those people who have to catch up tomorrow. And I only request, the dialogue has been so interesting that I myself has been carried over in many places. I request all of you for tomorrow, please join back and please follow the other participants. And thank you very much for the day. Thank you for participating.
Thank you.
Bye.
Thank you, Dr. Rao. Thank you for a good.
Bye. Bye. Bye.
Very good platform.